But the good news is we have someone as a replacement. Dr. Eileen Sawyer will be speaking about morbidities and mortality in adults with AMN.
Well, good morning, everyone. I am not Dr. Josh Bunkowski, but I am really pleased to be able to jump in to present you this work that we worked very closely together on, looking at the burden of illness in men with adrenomyeloneuropathy. So I don't need to tell this group about what adrenomyeloneuropathy is, so I'll just move right along on this slide. What is burden of illness, and why did we want to look at this? This is an experience that many people in this room live every day, the experience of going to different doctors, trying to understand different symptoms, manage them. And we hear about that, but what we really wanted to do was try and quantify some of those experiences in a way that we could look at the data in a systematic way and that could be persuasive to healthcare decision makers. So what we wanted to understand was really what is that overall healthcare burden, what types of problems are patients with AMN experiencing, and we also wanted to look as well at mortality. So that's what we set out to do. We were specifically as well looking at patients with AMN, and although we know that patients with AMN can convert to cerebral ALD, we were trying to really focus in on patients who were really experiencing the myeloneuropathy alone. So to do this, we obtained data from 2 different US insurance claims databases. And so that is that every time you go to the doctor and you submit a claim to your insurance for reimbursement, this gets put into a database. And so we were able to look at that data, specifically the claims that had been paid that had an AMN diagnosis code with it. So it was indicated as for a patient with AMN. To help understand how the patterns of healthcare use might differ, we also looked at patients who were similar to the patients with AMN who didn't have that diagnosis. So we matched them 1 to 4 with non-AMN men. Now, so this data is, it's got a number of limitations. There's a lot of information, a lot of questions we'd love to ask about it that we just don't have the information in the way this data is collected to answer. Like, for example, causality, sort of what's happening over time in the same individual patient. It may not be complete. We may not have the full picture for any one patient about what healthcare services they're using. So just keep that in mind as we go through the data. We also worked very closely with a specialized agency that does this. Their name is Precision HEOR, and there was a team there that helped us process and conduct these analyses because you start out with an incredible amount of data. So when you first get this data set, we had over 2 million patients that we could identify, and we ended up whittling that down through a process of elimination to try and get to the patients that we were most interested in. So we excluded patients, or we included patients who had at least one diagnosis code that was associated with AMN or ALD. We looked at adults only. We were also looking for patients that had no indication that they had the cerebral disorder. And this is difficult to do in this data set because there's no specific diagnosis code for adults with cerebral ALD. So we had to do that by that had pregnancy-related codes because we weren't sure if we were capturing some information around the the newborn screening and any prenatal care. So at the end, we ended up with about 800 individual patients that we could identify in the data set that we were fairly convinced had ALD or AMN. And then for the purposes of this analysis, we chose to focus in on the men specifically. So that gave us a sample of around 300. All right. And as I mentioned, we matched these patients with non-AMN patients on the basis of the demographics and basic characteristics we did not match. And I'll show you why in a minute on things like comorbidities, because that was one of the questions we wanted to ask. So on average, these were patients were around 30 years old. One thing that I should note as well, these are all commercially insured patients here. So these are people who have access to commercial insurance in this particular data set here in the US. We had a good age distribution and as well a regional distribution that relatively roughly mirrors what you see in the general population in the US. So when we took a look at comorbidities, and these were selected using the Charlson Comorbidity Index, which is a way of looking at the overall comorbidity burden that a patient has, we found that patients with AMN did have a higher rate of comorbidities overall than patients without AMN. As you might expect, you saw higher rates of hemi or paraplegia and non-diabetic neuropathy. That helps reassure us that we're probably looking at looking at the right populations here, that we're seeing some of that here. But surprisingly, we also found higher rates of a number of other comorbidities in this data set as well, affecting lung, liver, and cerebrovascular systems here. Rates of things like diabetes and other diseases were not different between the two groups. We then looked at utilization of various healthcare services. So this was any type of healthcare encounter, whether that be in an outpatient or inpatient setting, as well as use of prescription medicines, services like physical therapy, occupational therapy. And not surprisingly, we found that men with AMN do utilize more healthcare services across the board in all categories. They were hospitalized at 10 times the rate of the non-AMN cohort. They also had a higher rate of hospitalizations with an ICU stay. And when they were hospitalized, they stayed in the hospital for longer periods of time. Patients with AMN also used more outpatient services, again, across the board in every setting. They were seeing HCPs, healthcare providers, approximately, on average, 9 times a year. So that's close to almost every month. They had a number of outpatient hospital encounters, and they were also utilizing home health care professionals and visits as well. When we look at medications, we look at how many times patients fill a script at the pharmacy. So we found that patients filled the scripts around 18 times a year. So what that equates to is probably roughly something like 6 maintenance medications that the patient is taking on a daily basis, or it might also represent some shorter course medications in there as well. And the most common medication categories were for things like adrenal insufficiency, anticonvulsants. Here, this is probably actually representing some off-label use, we think, because gabapentin, which is used for some to treat pain as well, it gets categorized in this category, and also musculoskeletal medications. So to look at this information another way, when you're using all of these different services, what is the cost burden of that? And as you would expect, with these higher rates of service use, men with AMN had on average 10 times higher costs annually than patients who did not have AMN. Average adult male was costing the insurance agency around $3,000 a year, where a patient with AMN requires services that cost on average around $30,000. So we also wanted to try and look at mortality data because there's not a lot of really good information out there on what happens with patients with AMN. We couldn't do this in the commercially insured data set. It doesn't collect that type of information, and that is also probably introducing a little bit of a bias in the types of people who have access to commercial insurance. In the data set. So in order to do this, we looked at a different healthcare data set. That's the Medicare data set. There are a couple things to keep in mind as well. So Medicare is open only to certain populations in the U.S. So you can be eligible on the basis of your age if you're over 65. If you are under 65, you can be eligible for Medicare if you have a disability, or if you have end-stage renal disease, which is probably less relevant for our analysis here. But what's important to keep in mind is that the patients in the Medicare data set are likely to be sicker than the patients in the general population. So we took a look at mortality in this data set, both looking at in the patients with AMN, how many of them died and at what age did they die. And what we found is that a higher proportion of patients with AMN in the Medicare data set died in the observation period compared to the overall Medicare data set, a matched control, and as well to the general population. And this was true both for the patients who were under 65, who were disability eligible, as well as the patients who were over 65. When we looked at the average age of death, patients who were over 65, there was not really a significant difference in the age at which they died, whereas the patients who were under 65 who died approximately 10 years earlier than patients without. So to summarize, what we found here was really that AMN does impose a very substantial and I would say under-recognized burden on men with AMN. And we may, these data may also identify a previously unrecognized pathophysiology when we look at what we saw in some of the comorbidities that turned up at higher rates. I've addressed it a few times in this presentation. These data are limited. There are a lot of questions we can't ask, and these samples do come with a number of caveats around who's in them and what extrapolations you can draw from them, what generalizations. But I think this is a very important first step to quantifying that unmet need and highlighting areas where we need to dig in a little further to better understand what's going on and how to care for patients with AMN. So very importantly as well, I'd like to acknowledge Josh Bonkowski, who was supposed to be giving this presentation and really was a very key collaborator, as well as Chris Stephen at MGH and Florian Eichler, who also helped us out as we worked our way through this data set, and the team at Precision HEOR as well. Thank you.
Thank you, Dr. Sawyer. Okay, let's open it up to any questions. Ali.
Can you hear me? Oh, okay. Great presentation. I was wondering something that I didn't see there, and I wasn't sure. So in terms of mental health diagnoses, did you not look at them as comorbidity, or was it not different to general population? And then the non-AMN, was that sort of general population, or was that other disease cohorts?
So great question. When we were looking at the comorbidities, we did not specifically look at mental health diagnoses, but we were able to see a little bit of information related to that in the medication use. And we did find higher rates of medications like anti-anxiety, antidepressant, mood medications in the AMN population. Sorry, the second part of the question just reminds me.
Whether the control was basically just healthy people or disease.
Yeah, so for the control cohort, we specifically just matched on age, basic demographics. So they could have, we weren't looking for specific other diagnoses, but they could have had sort of anything else that wasn't AMN. So they had to be people who were seeking healthcare in order to show up in this data set, but we weren't looking for specific reasons why they were.
Any other questions? There we go.
Yeah, wonderful presentation. Are they planning any study for symptomatic women, the same kind of analysis? It would be fascinating.
It would indeed, and one of the things that we were able to get as we went through this was a cohort of women that we can conduct the same types of analyses through. So that is still in progress, but we have the information to do a similar exercise.
This is Ben Lanai. I think living with AMN, it reminds me of what George Orwell said about war, is that it's mostly boredom with brief moments of terror. And so I think a lot of the burden is actually in those moments. I would say the yearly MRI and waiting for the results, falls and all the complications from falling, weird adrenal events, and generally unexplainable bouts of fatigue and spasticity. And so, you kind of capture kind of the standard of care, but how can we capture these, moments of paroxysm and complications around the disease?
Yeah, that's a great comment, and thank you. So one of the things that we can't look at here, and that you sort of lose that level of detail in this data set when we're looking at things over time, annualizing it to sort of get that, as you say very correctly, standard of care picture of what of what the healthcare resource utilization is. But that all of that resource utilization could have happened in a 2-month period, and we lose that level of understanding in the way that we analyze this. And we also aren't able to correlate any of this in the way that we've done this study. It would need to be future work with the stage of progression that a patient is in. So in this data set, patients who are fully ambulatory versus patients who are not, we have no way to distinguish that. So it's a really great question and a good point, and something for us to certainly think about as we move forward in trying to understand this.
Luann here. Messy question, and I apologize if I just missed it, but did you folks distinguish that the AMN patients did not have cerebral ALD, and how were you able to do that?
That's an excellent question, and it was one of the challenges we faced in trying to do this study, is that there is no clear diagnosis code, and that's how we were navigating this data set for adults with cerebral ALD. So we looked at the data a few different ways. We did exclude anybody who had a diagnosis code of childhood cerebral ALD, but as you would expect with an over 18 data set, there were very few patients, and they were all around age 19, 20. I think we excluded maybe around 10 with that method. So we also looked at the data, plotted it out in a number of ways with the thought that if a patient had cerebral ALD, they would likely have a different pattern of resource utilization than patients who were just undergoing standard of care for AMN. So we were looking for sort of clusters of high resource utilization or a different pattern of inpatient hospitalization, sort of anything that might separate out a subpopulation. And we didn't see that. So we didn't end up excluding any patients that way. And what that told us was that if we do have patients with cerebral ALD mixed into this data set, their resource utilization is not different from the overall AMN population. Again, I want to be really specific, in this data set, which is commercially insured patients, which are, most likely to be employed, high functioning, sort of, it would be likely early stage.
I'm not sure if there's much relevance to this, but I'm just curious. In the statistic you mentioned about men with AMN being hospitalized at 10 times the rate of non-AMN men, what is the age range? Is it safe to assume that's older men or later in their disease progression? Or like what was the average age of those hospitalized patients?
Yeah, that's another great question. So we weren't able to look at stage of disease progression relative to resource utilization in this data set. That would be a very interesting question to dig into as a next step. So this was just across our whole cohort, and the age range was basically above 18, and I believe we had patients all the way up into their 70s in this data set. It was really across the board.
Thank you. I wanted to ask about the financial numbers you guys did. Why did you choose to do that, and how could an organization like ALD Connect use it either in our advocacy? But I guess and then is there like a context? Is that a low amount, a high amount compared with other diseases? I guess it might be low since there's no expensive drugs that we can buy since there are no real treatments, at least for AMN. So,
thank you for that question. So we chose to look at that because it is an important number for healthcare decision makers and policymakers, and a couple of sort of comments about what that number represents. So that number is the amount that is actually paid by the healthcare insurance company. So that doesn't represent the amount that they were billed for, so what they were actually asked for, because they may deny claims, they may have discounts negotiated, so it doesn't actually represent sort of that level of cost or value of the healthcare services that were provided. It also does not capture anything that the patient themselves must pay out of pocket, and so that's things like co-pays, if there are any caps that in medical services are utilized after a cap has been met, that would be the patient's responsibility. Anything that falls outside of a healthcare insurance purview, like home modifications, sometimes upgrades in durable medical equipment, things like that the patient may end up having to pay for themselves. So that is likely an underestimation of what the actual cost of AMN is. But with that in mind, it's still helpful for us to know that that is what the insurance agencies are paying, because it indicates that there's room to improve on the care and what we're delivering, and provide some impetus to argue for more efficient services that may help these patients do better and require less medical services overall. And compared to other neurological diseases, I would say this is in the range of other similar diseases that have similar levels of symptomatology and presentation. It's pretty on par with what MS was before they started having disease-modifying treatments, and the costs do go up a bit when that happens. I think we also looked at a couple of other neurological diseases that had costs that ranged from around this to a bit higher as well.
Any other questions? Okay, thank you so much, Dr. Sawyer.